This is Taylor, and I am hosting today's call on behalf of Nebraska Medicine and Methodist Health. So thank you, everybody, for joining us. Just want to give a brief introduction and go over some housekeeping. So we have Dr. Carrie Ward, Chief Medical Officer for CHI Health, Dr. Harris Frankel, Chief Medical Officer at Nebraska Medicine, and Dr. Bill Lydiot, Chief Medical Officer for Methodist Hospital and Methodist Women's Hospital. So thank you all for being with us here today. We are going to be recording this call, so I will send out a link to download it once it's completed, so everybody will have access to that. I also just wanted to say everybody is appearing as Taylor Barth in the call, so I apologize for that error, but the important thing is that you're all on the call. So if you could just specify your media outlet when you ask your question, that way I can share that with our CMOs so they know who's asking. So just specify again who you are with, and that will just help make things a little bit easier and organized. Again, I apologize for that error. And then we're just going to start with each CMO making a brief statement. So we're going to go ahead and start with you, Dr. Ward.
Okay, hi everybody. I'm Carrie Ward. I'm the Chief Medical Officer for CHI Health. I first want to express my gratitude to Governor Ricketts and the State Chief Medical Officer, Gary Antone, for their attention to this. The health systems have been working together incredibly well through all of this. And I want to thank Dr. Harris Frankel and Dr. Bill Lydiot with Nebraska Medicine and Methodist for all of their partnership with this. As we all know, as the governor said, COVID numbers continue to climb, and that's putting pressure on our resources. We have said all along at CHI Health, space is not the issue, staff is. We've heard from the governor about postponing all Class D and Class E procedures. No doubt postponing non-urgent procedures throughout the state will allow the specialty and the inpatient hospitals to free up staff to care for patients where they're needed. We support this directive, and we've already begun scaling back. Our move is not made lightly. At CHI Health alone, we estimate this change could free up about 40 to 50 beds per day and free up the staff who are needed to care for the patients in these beds. So the governor talked about Class D and E surgeries. It's a fairly simple classification process that's used around the country, where Class E surgeries are those that could be safely postponed for 12 weeks. Class D are those for 4 weeks. And so any of these cases, that's what we're going to be doing now. This means people may have to postpone procedures like some hip and knee replacement surgeries. We'll still have all the resources available to perform urgent and life-saving surgeries and procedures. In addition to postponing some non-urgent procedures, we will be delaying and assessing programs throughout our system that may free up additional staff. At CHI Health, we have 14 hospitals and 150 clinics across the state. So we will be pulling from every corner of the state so we can redeploy staff where they're needed. Of our 11,000 employees that work for CHI Health, not all of them are involved in direct patient care, but many of them are stepping up to help us through this process to increase our capacity to care for patients. Every one of these employees is essential during a pandemic. Capacity and staffing issues should change with postponing these procedures. This is why we went to a phased-in approach so we could adjust surgeries to the number of COVID cases coming in. This move does not lessen our commitment to care. We want to make it clear this is serious, but our hospitals at CHI Health in an extreme crisis will not be considered full until every operating room, recovery room, and hallway even are in use. Our staff are heroes. I want to give my incredible gratitude to the nurses, the doctors, the pharmacists, all the people who clean the rooms, every member of the staff, the respiratory therapists. They've been working incredible hours. They are heroes and they are tired, but they're committed to seeing our community through this pandemic. We have determined postponing non-urgent procedures and shutting down some programs is the best way within our hospitals to address the critical needs of our community. Outside of this, I just want to also give a plug that it rests with you. We need your help. We know that masks, washing your hands, and limiting gatherings works. With Thanksgiving right around the corner, these simple acts can make an enormous difference in controlling the spread of COVID. Today, at this moment, CHI Health has 250 COVID positive patients in our 14 hospitals in Nebraska and Omaha Metro. We have 75 of those in the ICU and 34 of those are on vents. I'm happy to say that the PPE, the masks and the gowns are not an issue. We have ventilators, we have drugs, We actually have about 470 ventilators that could be used at this point. So we have great resources there. And also can't say enough about our critical access hospitals. They have stepped up all around the state to care for a lot of these patients. They are caring for a lot of them that don't need an ICU level of care. They've been critical to this effort. As a reminder, we're still caring for strokes, heart attacks, car accidents at our ERs and trauma centers. We need to keep beds for them. If you have a minor illness, I want to stress, consider virtual care, walk-in priority care, or call your primary care provider's office. Our ERs are very busy. Next week, we're expanding our hours at our walk-in priority clinics in CHI Health. Please consider using those instead of the emergency rooms. So lastly, I just want to thank my colleagues, Dr. Harris Frankel, Dr. Bill Idiot, again, for joining us on the call today and for all their partnership through this.
Thank you, Dr. Ward. We're going to go ahead and go to Dr. Frankel now.
Thank you, Taylor, and good morning, members of the press. Carrie, thank you for your words. I could just say ditto and we could move on, but I will make a few comments. I too want to thank Carrie and Bill Idiot for their partnership and the work we've done together with many of our other colleagues across the Metroplex and Lincoln since the beginning of the pandemic. As Dr. Ward pointed out, this really has been a work of real cooperation and collective effort amongst the health systems in general, and specifically here in the Omaha Metroplex. I think people should feel confident that our belief that we are better together and the community is safer and stronger because of that collective and cooperative work. As Dr. Ward pointed out, space, though finite, is not necessarily the issue. We have been able to effectively create more beds and to date staff those beds. But as we continue with our contingency and surge planning, staff is really the issue. Notwithstanding the incredible resilient staff that we have on our front lines. And I would echo Dr. Ward's comments that it's all the way from the physicians down to the environmental service workers who are turning over those rooms as new patients come into our facilities. People are, they really are heroic in the work they do, but they're tired, no question about it. They've been doing this now going on 10 months, and they are putting forth all effort, and they are weary. We continue to look for staff to support them, notwithstanding the challenges that they all face. Their heart is in the right place, and I can rest assured, as I hope you can as well, that with the staff we have, this community is still in good hands. And quite frankly, there's not another place that I'd rather be under these circumstances. We've enjoyed our partnership in working with state government, Governor Ricketts, Dr. Antone, Matt Miltenberger. They have allowed us to bend their ear to help them in thinking about policy that they then recommend and or implement. The ability to work with our coalitions across the state as we work toward coordinated efforts in the movement of assets, both to acute hospitals and back away from acute hospitals when that level of care is no longer needed. That's been very positive. And again, I think makes us as a state a much better place because of it. As Dr. Ward said, the ongoing work ahead of us is far from done. We continue to see transmission rates, hospitalization rates increase. I think we all favor anything that would enhance the call to action for our citizens to adhere to the NPIs that we're all familiar with. At the end of the day, following those NPIs is what will really diminish transmission rates and reduce our hospitalizations. Going into this next week, we at Nebraska Medicine, with the modifications and creations of alternative care sites that have been made and the ability to staff those areas, we feel good about where we are moving into this weekend and next week. That could change rapidly. Again, as Dr. Ward said, we need your help. We need you to implore your family, your friends, even those people that aren't your friends, but who you can influence, to adhere to the NPIs. It is incredibly important that we do that. We probably can't affect the trajectory over the next couple of weeks, but we certainly can affect the trajectory beyond the end of November if we do these things. And that's critically important. As you've heard, it's not just COVID patients that are occupying beds in our facilities. We have a responsibility to the community in the region to take trauma, complex cardiovascular and neurovascular cases, transplants, et cetera. And the need for acute care services with that population of patients doesn't change. That being said, at Nebraska Medicine, and as I alluded to earlier, flexing, following surge plans is something that we do on a frequent basis. We've just had to expand that footprint. And I am absolutely astounded by the great work that has been done in our facilities to accommodate the increased number of COVID patients, which represents about currently 25% of our inpatient population. And that's a group of patients that historically we have not had to care for. As we move into the flu season, that is yet something that we have to consider when we're talking about the capacity of our facilities. As you've heard, and as has been demonstrated in the Southern Hemisphere to date, the adherence to NPIs has resulted in some reduction in flu cases in those areas. Whether or not we see that remains to be seen. I'll conclude by saying that, again, I believe that Omaha is in as solid a position, given what we're facing right now, as we can be in. We know there's work to do. We know we could face challenges. And as Dr. Ward alluded to, we very well could exceed capacities if the transmission rates and subsequent hospitalization rates don't decline. We are prepared to face that if we come to that, but we need everybody's help. And again, I just want to give my heartfelt thanks to all those on the front lines, everybody who has made the care for these patients possible and still maintain the safe, high quality environments in which they're cared for. So thank you.
Thank you, Dr. Frankel. Dr. Lydia, we'll throw it to you now.
Thank you very much, Taylor. And thank you, CHI Health, for hosting this. I want to also echo what my two colleagues, partners, and friends have said, and that is thank you to all of the work that has been done between our health systems. It has been one of the highlights of my career to see the kind of interaction between competitors that we have had. And I say this in part to thank Harris and Carrie, but also to thank all of the staff that have been working together between the systems. And more importantly, I say this as reassurance. We are working together. We will not have a crisis level of care until every bed is filled and every ventilator taken and every drug used and shared. And we can pledge our honor on that. Methodist health system is currently full, but we still do have capacity, much like CHI and Nebraska Medicine. We're doing a number of different strategies following our surge plans. We have postponed non-urgent cases over the last 2 weeks in order to free up beds as well as to free up staff. And just so you have an awareness of what happens, we have pre-op nurses, we have post-op nurses, intraoperative nurses, and then floor nurses, all caring for patients. And as we diminish that number of surgical cases, we free those people up to go to the bedside and help out our colleagues in the wards. We're also looking at all other options to free up staff, including from our clinics. And like my colleagues, from the bottom of my heart, I want to thank all of our staff, our nurses, our phlebotomists, our nutritionists, environmental services workers, our physicians, all of the staff that are working incredibly hard through incredible odds, through wearing very uncomfortable PPE, going in and caring for people again and again and again, and doing it with compassion and with honor. Their selfless dedication is a model and a goal for all of us. 32 years before Nebraska became a state, Alexis de Tocqueville stated, "The ingredient that makes the American experience successful is self-interest, rightly understood." What he meant is that our rugged individualism provides the secret ingredient that powers our economy and our society. But he noted, we rightly understood that each of our own self-interests are inextricably tied to our communities and to our friends. My parents married in 1942. Several months later, Dad shipped off to fight overseas. He returned 3 years later in 1945. Their generation didn't start out as the greatest generation. They became it. We must all recognize that each of our own self-interests involves doing things to protect and help others. Our nurses and our other bedside and frontline staff exhibit that all the time. Today, for all of the public, it means this: wear a mask when in public or when within 6 feet of people. Avoid crowds, including large Thanksgiving celebrations. Avoid confined spaces and wash your hands. Our generation can become the next greatest if each of us does our part. Thank you.
Thank you, Dr. Lydia. Now we're going to open it up to questions for the CMOs. I have a couple submitted in the chat, but I just want to remind everybody, please submit your questions so that we can get to those. Please also include what media outlet you are with. And if you have a question for a specific doctor on the call today, please specify that as well so I know who to ask your question of. So we'll go ahead and direct the first question at Dr. Ward. It is, maybe you plan to address this, but are the measures the governor announced today enough to relieve the pressure on hospitals, or is it too late given the 2 to 3 week lag between surges in new cases and when some percentage of those folks arrive in hospitals?
So there's no doubt there is a lag. So we do expect continued growth for a period of time, no matter what we do. But the governor did institute measures that, if all followed, personally, I have absolutely no doubt will reduce further disease transmission. And I want to stress, I know there's a lot of discussion, controversy about whether there should be a masking mandate. There doesn't have to be a masking mandate if we all wear masks. And if everybody would do as Harris and Bill and I and every other healthcare professional we know could just follow the rules, don't need to debate the politics or where we stand on a mask mandate, other than to say we all believe that masks work. And as Bill so well said, 6 feet apart, and if not, wear masks. That will do an enormous amount of good. And those are the things that are in the governor's plan. So yes, I do think that those measures can significantly reduce disease transmission.
The next question we'll give to Dr. Frankel. They were also asking, is this too late? But they would also like to know, how much would a statewide mask mandate help should it be considered?
Well, I will absolutely echo what Dr. Ward just said, and I would go further to say this. I think it's unequivocal that all of us would favor any strengthening of a call to action to follow the MPIs. No question, you're always going to have individuals who choose to exercise their individualism over what is otherwise perceived as something in the better interest of the public. Would a mandate achieve that? Without directing my comments to anyone in particular or any body in particular, I think there is likely to be a higher rate of participation when things are mandated. Do I like personal mandates? I don't. And you're not going to change the minds of those who don't choose to follow those recommendations. I think that Nebraskans are they're resilient. I think they tend to do what's best in the interest of their fellow citizens. But I think we would all support anything that would strengthen the call to action to get people to adhere to the NPIs. We know, as Dr. Ward has clearly stated, that we have to stop the transmission. And the masks, albeit just one of the tools, are incredibly important. And there's even new science that has been published that supports that belief. I think time will tell, but every day is one day further down the road that we will have to contend with.
Thank you, Dr. Frankel. Dr. Lydia, the next question is from the Lincoln Journal-Star. What's the average stay for a COVID-19 patient compared with, say, someone hospitalized with flu complications?
Yeah, that's an excellent question, and it gets to part of our problem. There's a couple things I'd mentioned with this before answering that specific question, and it is that we look at COVID positive patients, but we also have a cohort of patients. At Methodist, it's about an additional 25% or so of patients who are COVID recovered. So they're no longer infectious because they've been here for past their infectious period, but they continue to be in the hospital. And so that gives you some idea. If they go through a 28-day period of potentially being infectious, that means these people are here beyond 28 days. And that's up to 25 to 30 additional people in over and above our 90 to 95 COVID positive patients. So in general, the stay is up to 50% longer, and it will also go up even further for ICU care. So it's a substantial number of days. We looked initially overall, and our days were 10.5 for a length of stay for a COVID positive patient, all comers. We believe that has gone down with the way we've been able to manage our care. It's probably still, though, 5 days for a regular and 7 for ICU care. So significant.
This is a question for all three of you. So we'll start with Dr. Lydiot. What is the percentage of COVID-19 patients at each of the 3 hospital systems?
We're at about roughly 25% of our patients are COVID positive.
Dr. Frankel?
Yeah, we're the same here at Nebraska Medicine, 25%.
About the same at CHI Health.
Okay, thank you all. The next question comes from Andrew Ozaki at KTV. On one hand, you say you could exceed capacity if cases don't decline, but on the other hand, you say we have enough drugs and ventilators and will not turn anyone away. What will happen if hospitals are overwhelmed? Dr. Ward, I believe it is your turn.
Well, another thing, a great example of us all working together is across the state, we've put together a crisis standards of care tool. And I want to thank Steve Doran. I think he's a neurosurgeon in Omaha, and that has played a lead role in putting this together. We've had a lot of discussions with the governor, with the state chief medical officer about this. And we do have a plan in place. All states, or most states, have some sort of formal plan that addresses the proper allocation of limited resources. So making sure that the patients who are going to benefit most from those resources receive them. And I'll let my colleagues say more about that if they would like, but we do have a very clear, consistent plan in place to deal with that situation should it arise. I want to let Harrison build.
Yeah, thanks, Gary. I'll be happy to expand on that. So, I think it's fair to say that on a daily basis, we do everything to provide the greatest amount of benefit to the greatest number of persons who are receiving care. And at the end of the day, regardless of the situation, we will continue to provide, to the best of our efforts, those things that provide the greatest amount of benefit to the greatest number of individuals. Now, the situation in which that philosophy occurs may be different based upon the local environment and the availability of resources, as Dr. Ward described. And so I think what the public needs to understand is that our philosophy about maximizing benefit in the work and care that's provided doesn't change. What does change is the fact that where we didn't necessarily have to make forced choices in a routine environment, we may be placed in a position, not by choice, but by circumstance, of having to make forced decisions in a unique environment. That being said, Dr. Ward alluded to the crisis standards of care, and each institution has developed those. We are working collectively with our coalitions to have a plan statewide, but basically follow guidelines that inherent in those are principles based in sound ethics of fairness, of transparency, of maximal benefit, to guide those decisions, that in the setting of where the demand exceeds the resources, appropriate and fair decisions can be made that maximize the benefit for those who are receiving those, and in the context of the larger population, not necessarily at the individual level.
Dr. Lydia, did you have anything to add to that?
I think Carrie and Harris have said it very well. I think I'd come back again to something that we had talked about earlier, and that is our relationships that have been built over this last 8 months, not only between the health systems, but across the state through the work of CHI and the COVID Transfer Center. And really fundamentally important in this is our relationship with Gary Antone at the state, and the governor and his chief of staff, Matt Miltenberger. They have been very receptive. We feel like they have helped us in terms of trying to keep the line of sight across the entire state to always do everything we can to avoid getting into those situations that Harris so aptly described. So I think, you know, I get the tenor of your question there. We do have capacity now. We can do additional things to create more capacity. You know, the specialty hospitals, for example. Right now, we don't need to utilize them, but they have staff, they have nurses, they have beds, you know, they have ventilators. So there are a number of potential options to which we can avail ourselves should that need arise. And we do so on a moment by moment basis. And we do so, again, as Harris said, with the fundamental principles of ethics and fairness, and absolutely careful weighing of who's likely to benefit the most from any given treatment. Not done at the individual level, as Harris said, but really done across the board, and trying to have these things in position and in place. A good example, I think, is remdesivir. Remdesivir is a drug that we give to our COVID positive patients, but you know, the data does not support its use in a number of different situations. Just having COVID is not an indication for its use. So we restrict its use to those patients who have had where there's evidence that it is beneficial. And by doing so, it might seem like that's rationing. I would argue that's actually using the appropriate decision-making to put the evidence of what works best and get the right drug in the right person at the right time.
Thank you all. Julie Anderson from the Omaha World Herald has the next question, and Dr. Frankel will give this one to you. Can you give examples of where crisis standards of care might come into play?
Well, I think that if you recall the words Kerry uttered in his opening remarks, and were really have been echoed by all of us in our commitment to the same, that until every bed is filled, until every resource is exhausted, and there's nowhere else to turn, that would be a situation which we would likely enact crisis standards of care. We're committed to our ongoing work with one another, locally and quite frankly across the state, to maximize utilization of every resource possible. And until such time that we can no longer effectively manage things and there aren't those available resources that meet the demands for same, it's at that point that crisis standards of care would be enacted. Now, that being said, it's important to understand that foundational to any crisis standards of care plan is a framework that really describes the continuum of moving through care from conventional care to contingency care and to crisis care. And I think it's fair to say, and not to alarm people, but I think it's fair to say that given all the things that have been done and that we are doing, from modifying existing spaces to accommodate COVID patients, to creating new spaces to accommodate COVID patients, to cutting back on surgical cases to make room for more beds to accommodate COVID patients, to recruit ambulatory staff to come work in the inpatient environment to care for the additional COVID patients and support those already on the front lines. All of those things are reflective of contingency care and surge, contingency operation and surge planning. As I said, many of these activities we are used to at lesser volumes, perhaps, but we are doing those things and we are adept at being able to do that. At the point where there are no more chess moves, if you will, and there's no other board in which to put our pieces with our colleagues in the community and across the state, I think that's where the trigger becomes flipped.
Follow-up question. Oh, go ahead, Dr. Ward.
No, I would just very quickly add, agree with everything Harris said. I do want to thank the governor for, I think what we've already said this, the $40 million, astounding amount of money that they were able to provide for us to get additional staffing. We all have some nurses on the way. It's been a challenge to get them because everybody across the country is trying to get additional nursing, but we do have that resource available. That will free up beds, beds for us. Also, I want to call out Kristen Bloom. She's the director of the transfer center at CHI Health, and she's been leading the state transfer center. That has also been a great resource. Everybody has been so cooperative with trying to make sure we have patients distributed in the best place for them, including the critical access hospitals, hospitals east and west, and that has helped us avert any sort of crisis situations also. So
the follow-up question is, just so I'm understanding correctly, are you talking about rationing care if hospitals become filled? How much beds do you need to keep in reserve for emergencies such as accidents, shootings, et cetera? Dr. Lydia, do you want to address that?
Yeah, I think that brings up an important point, which is that COVID is certainly what we're focused on, but and we may have 25% COVID patients, but that means that we have 75% non-COVID patients. And so we are constantly working and dealing with all types of different things: strokes, heart attacks, other kinds of medical illnesses, accidents, trauma, as you point out. And so really, we take this all in totality. We don't separate and say that a COVID patient is going to be in a crisis level of care while someone else isn't, or we have beds available for trauma, but we don't have beds available for heart attacks. You know, we deal with this on an ongoing basis, day in and day out, 365 days a year. This is just what hospitals do. We manage with the appropriate resources for the appropriate people with the appropriate illnesses, and we put them in the best position to walk out of the hospital better. And so I think that's important for us to understand, that this isn't just about COVID. This is about healthcare. And I'd come back to that point about, we're all in this together. And it doesn't matter what your view on COVID or masks or anything else is. We're all in this together, and we're all caring for each other. And none of us knows when we're going to need an acute care bed in a hospital, or a drug, or a physician, or a nurse, or a respiratory therapist. All of those things are resources. All of those things could potentially be stressed and limited. And we have multiple different contingency plans to every extent that we possibly can, including sharing among institutions.
Thank you, Dr. Lydiot. Another question that was brought up, the governor mentioned prohibiting Class D and E surgeries. Can you give examples of what kind of surgeries these are? What is being prohibited? Dr. Ward.
Well, I'll take a stab. Bill is the surgeon of the three of us, and maybe I can give a few better examples. But just one example I gave opening was a joint replacement. That's I think a fairly good example of a surgery that no doubt the patient has pain, a quality of life issue, but some joint procedures can be delayed, and that's a decision a physician and patient come together on, and then we will let the physician and the patient determine if this is something that falls into that category. If the patient is in severe excruciating pain, can't respond to the normal medicines and all that, that would fall into the urgent category, and that would not be delayed or postponed. But we will be working very closely with our surgeons and our patients to make sure that those things that can be safely postponed will be. Those that can't, as I said before, we all have the capacity to care for those. So I'll let maybe Bill, if you want to say anything more about surgical perspective.
Sure. Yeah, thank you. Well, actually, Dr. Ward really summed it up very well there, and then again in his first talk, and that was those things that require basically that can safely be put off more than 4 weeks without adverse outcome. So you might think on the converse, a cancer patient that has a cancer that's growing near their larynx, something we deal with in my field. Those people are going to have more and more difficulty breathing. They're going to come in as an emergency, and the goal is to avoid that. And I think that the point that Dr. Ward made is really critical. These are medical decisions, and they're made in good faith by the physicians that know the patients. And they present their case, and then I believe each of us have special committees and evaluation teams that are composed of surgeons from multiple specialties that help to make that decision as well. It's not an easy decision. We all, as physicians and certainly as surgeons, we come in and say, yeah, but my patient needs it, because we are advocates for our patients. And so the goal is to try and be fair, to try and respect what is going to be necessary, but most fundamentally important is to care for the patient in the best and safest way. And this is just one more example of where we have to compare and weigh certain things. We would love to do everything for everyone, but when D&Es are requiring a bed, then those are the ones that we're going to be postponing.
Julie Anderson with the World Herald also wants to know if you can talk about what a Class C surgery is. Then I believe that was the next tier on the governor's plan.
Yes, I'll take that if that's okay with you too. Class C basically is something that needs to be done within 4 weeks, or the patient could potentially suffer an adverse outcome. Now, it's again, not as obvious as it might seem, but let me go back to what is an A. So an A is an emergency that either life or limb will be lost if it's not done right away. B is an urgent, and if it's not done within 1 to 2 days, that's a situation. So the A case would be someone whose airway is lost. And if we don't do a tracheostomy or intubate, they will die. That's an A. A B is someone who is, for example, has acute appendicitis. That patient can live a little while. We can do antibiotics and things for some time, but oftentimes those cases need to be taken to the operating room in order to remove the infected appendix. A C then would be also quite a spectrum. So certain cancers, again, I'll use the airway cancer. It is a C case by definition, typically, unless they're acutely having an airway crisis, they're someone who will likely develop one over the course of perhaps 2 weeks or so. And so that would be what we might consider, I think Nebraska medicine calls those a C1, which would be, has to be done within 2 weeks. And a C2 would be those that has to be done within 4 weeks. But typically you're going to see cancer cases in this group, certain heart cases, coronary artery bypass grafting that can be done, that can potentially be medically managed for some time, for a short time, but does need to be done. Perhaps valve replacement surgery. That might also be a D. It just really comes down to the specifics of the medical situation.
Dr. Frankel will ask this question of you. If you are all at about 25% COVID patients now, when do you predict we'll be in the red on the governor's schedule? That's from Julie Anderson at the Omaha World Herald.
Yeah, well, that's a good question. And I think that question needs to be framed in the context of the other 75% of patients that are non-COVID that customarily live within our facilities. We believe that we have the ability to take on some additional COVID patients. But at the same time, we have to balance that against the specialty services that we provide here at Nebraska Medicine that largely relate to a lot of complex care that some of which is done here specifically. Not every institution deals with acute trauma. CHI, Creighton University Bergen Mercy Medical Center, is another one in the community that does that. But we have to take, trauma. We have complex cardiac cases that come here because of some of the expertise that our cardiologists and cardiothoracic surgeons have, where certain things are just by the nature of the illness come here and because of the physicians that provide those services. So we have some ability to take on more COVID patients. And as I alluded to in my initial remarks, we have expanded our footprint to care for additional COVID patients. But again, we are, by taking on more COVID patients, we are squeezing our ability to care for these other complex, highly acute patients who otherwise seek care here.
This is Kerry. The only thing I'd add, thank you, Harris. The only thing I'd add to that is the numbers. I was just thinking about the math when the governor was presenting this today. He said we have about 900 hospitalized in the state. And I think he said the 25% was somewhere around 1170, maybe. And he said we're growing at about 25 patients hospitalized a day. That's 8 to 12 days we could be if we continue that rate. And I think I may not have thought this a month ago, but that certainly could be the case. I mean, I don't think any of us would be terribly surprised if we were at that number. So we may be looking at the red within a couple of weeks.
And I'd also like to point out as well, I think Dr. Ward's exactly right about that timing. That's, I think, what the governor projected. I think that's what we're all potentially being prepared for, given that we've had very high rates of positivity in the past week. So we certainly are anticipating that. But I would also emphasize that We are doing this on a daily basis in our own institutions. We have been stopping D&E surgeries now for 2 weeks. Not all of them, but very, we're selecting which ones need to stop and how many beds we need, and we're trying to make this on a very careful basis so that we can do as much and we can care for those surgical patients to the extent that we can. But we've also stopped outpatient surgery in order to free up staff. So, we're doing things that would even be beyond the governor's plan, though we think what his plan is trying to do is correct in terms of looking at this broadly.
Taylor, this is Harris. I'd like to make one other point if I could. What we've not addressed specifically, though, that I think is very important, is that I firmly believe, and I think that Carrie and Bill would agree, that our health systems are still safe environments, and that people should not avoid coming to the facilities when it's appropriate for fear that the environment is not safe. I think that everything that we have all undertaken within our facilities and the provisions we've put into place, we can still confidently say that you are safe in our facilities. And as relates to the emergency departments, we saw early on in the pandemic, for instance, individuals with acute stroke symptoms, there was a 40% reduction in the presentation of those patients to emergency departments because of fear of getting COVID at the facility. I think we want to dispel those myths that the emergency room, though they may be busy, they're a safe place and the right place for the right person at the right time. And if patients have any questions, they first and foremost need to talk with their physicians. If they have any concerns, though, and they're familiar with emergency signs and symptoms, come to the emergency room, call 911. Do not be afraid to come to the facilities for fear of COVID. It's imperative that you address your acute health needs.
Well
And
said.
I want the public to understand and have confidence in the fact that the health systems, the hospitals, and even for those with chronic conditions who have deferred routine appointments with their physicians in the clinics, collectively, the health systems, the acute facilities, the clinic are still a safe place to seek care when you need to do that.
Thank you, Dr. Frankel. Dr. Ward or Dr. Liddy, do you guys have any closing remarks you'd like to make before we wrap up here?
I just thank, again, Harris and Bill for joining us and all of the partnership we've had, all the great work. Again, my gratitude to all those providing care to our patients. And thank you all for giving us time to visit with you today.
Likewise, I'd like to thank you, and I don't have anything further to add other than I completely echo what both Carrie and Harris said. I think we're all on board and all completely aligned with how we move forward, and we feel like we have the necessary steps in place to keep everyone safe and to be successful weathering this COVID surge.
I would agree with both
Thank
Bill
you.
and Carrie
Oh,
remarks and again reiterate the work together has been terrific. As I said, I think as a community, we are better when us as health systems are working together. And I think the community should feel confident that we are providing a safer and stronger environment because of this work together. And so long as we remain together and continue to have conversation and continue to implore our friends and families and loved ones to do the necessary things that we've discussed, we'll get through this.
thank you, all three of you, for your time today. Thank you to all the media who joined the call. Again, I will be sending out a link to download the full call. So look out for that in your inboxes shortly, and hope you guys all have a safe and healthy weekend. Thank you.